Hi everyone, welcome to GoggleDocs series on heart failure, where we'll be taking an in-depth look at the topic of heart failure, not only in the realms of diabetes, but beyond that as well. Before we get going, we'll introduce ourselves again. So over to you, Kevin.
Hello everyone, Kevin Fernando here, GP partner at North Berwick Health Centre, just near Edinburgh, long-standing interest in diabetes and medical education.
I'm Patrick Holmes, GP in Darlington in the north of England. Yeah, that's me.
And I'm Albertana, a diabetologist consultant in the West Midlands.
And I'm Rick, GP based in North London with an interest in diabetes and education as well. Thank you for joining us again for this, for the first in this series on heart failure. I suppose the question, why heart failure? Why are we looking at heart failure? Well, Amma and I are going to have a bit of a chat about that, introduce the topic really. Now, according to the latest statistics, we have approximately just over 600,000 patients on GP registers diagnosed with heart failure. However, that's still missing over 300,000 diagnoses. So there are lots of diagnoses of heart failure, which currently are under the radar in primary care. Now, we know that heart failure actually is a condition that increases in prevalence with age. We know that the older the person, the more prevalent it is. In fact, when we get to the patients who are over the age of 70, the prevalence increases from around 1 to 2% for the general population to over 10%. Now, Amma, that's probably because of the collection of multi-morbidity, isn't it, as patients get older? Is that right?
Yeah, I mean, you mentioned, you hit the nail on the head, the term multi-morbidity. We're seeing that more and more with lots of medical conditions, and heart failure is no exception. There's some data showing that actually just about 90% of people with heart failure have about 3 or more comorbidities when they're when they have been diagnosed formally with heart failure, which says a lot about kind of the population, but also the implications of that diagnosis on top of everything else that they have. Some of the traditional kind of factors up in people who have heart failure, the associated conditions include coronary artery disease, which is one of the well-known reason why people do get heart failure, but also things like hypertension, genetic links. But more recently, part of the reason is the increased prevalence of obesity and type 2 diabetes, which is, again, now we're realizing more and more how much of an impact that has on heart failure and the risks of heart failure and development of heart failure. You might think because of the recent diagnosis, all the recent trials and data showing heart failure and diabetes with some of our new medications that, this is only a recent thing. But we've known about the links between diabetes and heart failure, metabolic syndrome since really Framingham, 1970s or so. So we know it for a long time, and the risks associated with heart failure and from my point of view, type 2 diabetes. But really, it's kind of, it's come back on the radar even more so recently.
And what's interesting also, Amma, is that it's the only cardiovascular disease that actually has an increasing prevalence compared to the other types of cardiovascular diseases that we have. So very much relevant for us, not only in primary care, but also secondary care as well. And I suppose it is a condition that involves both primary and secondary care, very closely, because you'd have thought that most patients are actually diagnosed in primary care and then may have hospital admissions, but actually 8 in 10 patients have their diagnosis in an acute setting. And that's, to me, that was quite a surprising statistic.
Yes, I see that a lot of the times, from the take or when we're on the wards. The number of people who we diagnose with heart failure for that first time is certainly, perhaps been more aware of it recently, but certainly it's always been the case where someone's come in with shortness of breath or something, and you pick up on certain things and certain risk factors, and you consider that. And I'm sure we'll go into more details of that in these talks. But yeah, I've seen a lot of initial diagnosis of heart failure in secondary care, certainly.
And there's also the progressive nature of the condition as well. Perhaps initially just with symptoms. We mentioned hospital admissions. Really impacting not only on the patient's morbidity there, but also in terms of the costs to the health service as well, and then the health systems. And that progressive condition often ultimately leading to, a fatal and a terminal condition as well. And it's actually unfortunate and quite sad to see that very few patients who are with advanced heart failure actually end up having a palliative care referral. And it's clearly an unmet need there.
Yeah, I mean, just that first hospitalization for heart failure, that's associated, is someone admitted, for the first time with heart failure hospitalization, 30% mortality risk for that person. And once you've got advanced heart failure, the 5-year mortality is 50%, which I think you might have heard this before. It's comparable to some cancers as well. I think that's the kind of the hard-hitting headline that a lot of people use with heart failure. And that first admission for heart failure, that predisposes to recurrent admissions for heart failure as well. So the importance of preventing that first admission of heart failure is equally just as important, and that's where risk factor management comes into it. We're well aware of from primary and in my diabetes setting. So yeah, very important topic, very important area.
Okay, so some hard-hitting statistics there. And I think what we would like to do actually over the course of not only this episode, but the episodes to come, is to work through a case study. We think that will be quite a good way to look at the practicalities of not only identifying and diagnosing heart failure in the community, but also managing it as well, and how the multidisciplinary team really interacts in the management of these patients with heart failure. So Kevin, I'm going to hand things over to yourself because you have a case study to share with us.
Yeah, great. Thanks, Amrit. Thanks, Amma, for that introduction. Heart failure very much is something that affects both quality and quantity of life, isn't it, for our patients living both with and without diabetes. So yeah, I just wanted to take us all through a case study, someone typical that might present to me, Patrick, or you, Amrit, in primary care. And of course, it's great to hear Amma's secondary care take on this as well. So we have Fatima. She's a 55-year-old lady of Bangladeshi origin who's been living with type 2 diabetes for over 10 years now. So quite a considerable duration of time. Also of note, talking about comorbidity, she has a background of hypertension too. Current BMI is 33. And her current medications prescribed by ourselves, metformin, 1 gram twice a day, which she tells me she's taking regularly and is tolerating okay. She's also on pioglitazone, 30 milligrams daily. For a hypertension, she takes lisinopril, 10 milligrams, and she's also on atorvastatin, 20 milligrams for the primary prevention of cardiovascular disease. So unfortunately, as with many of our patients with chronic disease, she's not really had a chronic disease review for a while, certainly before the pandemic. So the bloods at her last diabetes review pre-pandemic, her FBC and UNEs were normal. So specifically, her EGFR was over 60 mils per minute, and her HbA1c was 64 millimoles per mole, or 8% in old money. So she unfortunately presents to us in primary care with progressively worse shortness of breath, really on minimal exertion. She used to be able to walk a good distance on the flat, but is really toiling with even short distances. On further questioning on systemic inquiry, she seems to describe 3-pillow orthopnea as well, and also describes a worsening ankle edema as well. Okay. So we examine her pulse is 84 and regular, current blood pressure 162 over 94 millimeters of mercury. We have a listen into her chest, auscultation reveals sparse bibasal crackles, which actually largely clear on coughing, and she has pitting edema to both shins. Heart sounds are dual, 1 + 2 + 0, and her JVP does appear to be a wee bit elevated. We also check an ECG, which reveals sinus rhythm, but evidence of LVH, left ventricular hypertrophy in the chest leads, and also Q waves anteriorly. So what do you think about Fatima? Quite a lot to discuss there, but a number of things I'm sure we can all immediately pick out there for a bit of further discussion. So Patrick, anything jumps out to you there about Fatima?
Yeah, well, from what you've told me, I mean, there's quite a lot, is there? If I just perhaps take on the medication side of things, she's on pioglitazone. I mean, a good drug, in terms of glycemic control, particularly actually in women with an elevated BMI, but not great in this situation. I suspect it's causing some of that fluid retention, and simply stopping that medication, may actually improve some of the symptoms. So that's the one I would, which I would go straight to. There are others, but I'll let others, I'll let the younger guys around here pick out some other features, perhaps in that history.
Absolutely. Pioglitazone is essentially contraindicated, isn't it, in heart failure? It causes both peripheral edema and central edema. But there's cautions, isn't there, in using it in macular edema as well. So I completely agree with you, Patrick. For someone like Fatima, that risk-benefit ratio is just not favorable, is it, for pioglitazone? What about you, Amrit? Anything jumping out at you there from Fatima's case history?
Yeah, picking up from where Patrick left off in terms of the diabetes element of this case, I'm going to focus just on the HbA1c. First of all, I'd like to get a bit more history from the patient, maybe a bit more social history, find out things like occupation, but also functional status as well. I'd like to get a bit of a better idea of whether she has frailty or not, and to what extent. But then I'm really looking at what her HbA1c target would be. And that might be something actually I throw out open to the three of you. But also the other part of that is it worth, if it's been over a year since we've last had any blood tests, to repeat the blood tests, get an up-to-date HbA1c, but also other things such as renal function. What do the three of you think about repeating blood tests at this stage, and therefore also moving on to the HbA1c target as well? What your thoughts are about that?
Yeah, I mean, I'd take probably the second one first in a way, because I mean, I would want to check the blood test more accurately for a number of reasons, baseline values, but also for me, an HbA1c that's over a year old is irrelevant in a way. I want to know what's happening now. So HbA1c, I mean, very important, as you know, prognostic indicator in a way of diabetes complications. One of the things that strikes me with HbA1c is that in the setting of heart failure, if we're considering that, which spoilers, we probably are in this case, is that those, HbA1c is associated with increasing, 1% increased risk, 1% rise in HbA1c is associated with increasing risk of heart failure. So, I'd want to look at that from that point of view alone, but also generally in terms of reducing complications and the risk and the burden to that person. I'd want to optimize that HbA1c. And what was it at the moment? It was 60%, wasn't it? 64, yeah. That's, again, from my point of view, of course, with everything else going on a bit on the higher side, I'd want to, get it down to that target 7% or even below 7.5% for a woman, isn't it? So,
yeah, I would absolutely agree. I mean, she's a young lady, only 55. She has a good functional status. I know you were querying that, Amrit, but she absolutely good quality of life. So I'd be aiming for 53 millimoles per mole or less, ideally. What about you, Patrick? Do you think that's reasonable? Yeah.
Absolutely. I mean, obviously, currently she's not on any medications which lure would not lower her HbA1c to a level or blood glucose to a level where she's going to get hypo. So I'd look for someone of that age to get them as low as possible without hypoglycemia. So obviously, some of that will depend on the medication. But yeah, she's, as you say, 55. If she's, there's no elements of frailty, we need to be getting that HbA1c down.
Given what you've all said, I agree. I'd be hovering around the 53, possibly. You're thinking she's had 53 millimoles per mole as a target. She's had diabetes for over 10 years. Perhaps just need to bear that in mind. We're not dealing with someone who's newly diagnosed, where we can be particularly intensive with the therapy. But based on that, also bearing in mind what Amrit said about potential of heart failure and risk of heart failure, and the fact that her BMI is 33, we want to try and encourage potentially some weight loss there as well. So I would be thinking about an SGLT2 inhibitor in this situation. We know that an EGFR, if we can repeat it and ensure that it is over 60, well, that gives us quite a lot of reassurance in terms of using SGLT2 inhibitors across the range of options. So that's what I'd be thinking in terms of the A1C.
Absolutely, we're all in agreement. We need to tighten that HbA1c. Well, we need to get up to date HbA1c and then aim to tighten it if indeed it is still around about that. What jumped out to me from the case history was the blood pressure. And blood pressure is suboptimal, isn't it? 162 over 94 millimeters of mercury. Once again, coming back to Amar's comorbidities, that combination of diabetes and hypertension is not a good combination, is it? Oh, I should say uncontrolled hypertension. So that is further increasing her lifetime risk, isn't it, of cardiovascular disease. So I'd want to definitely get a few more values there. So, of course, very much the direction of travel is home blood pressure monitoring, isn't it? So ideally, I'd like her to do some home blood pressure monitoring to see what our home blood pressure averages are. But if indeed that is a true value, absolutely, I'd be looking to escalate, intensify our antihypertensive therapy. She's on a fairly low dose of lisinopril, isn't she? Just 10 milligrams. U&Es are okay. Of course, we need to get those updated, but I'd definitely be looking to ramp that up. I mean, NICE actually in the updated hypertension guideline from 2019 suggested, we should be aiming for less than 140 over 90 for they've slightly relaxed the blood pressure target. I wasn't too comfortable with that. I mean, I know that data comes from the CORD trial, doesn't it, Patrick? But certainly someone like her, if tolerated, I'd want to get her down ideally to something like 130 over 80, millimeters of mercury. And also I probably want to check standing and sitting blood pressures too. She's got type 2 diabetes. Is there any element of autonomic neuropathy there? And go for look at the standing blood pressure in particular as a target. And perhaps even check blood pressure on both arms as well. That was an interesting nugget from NICE, wasn't it? If there's a significant interarm difference, that might be suggestive of peripheral arterial disease as well, because the bottom line is, sadly, she is a vascular path, isn't she? She is at high risk of cardiac. So a number of things, as you said, as you've all brought up, that we can discuss about our case history. But as Amar said, spoiler alert, we are suspecting heart failure here. So what do we do next, Amar? What are our next steps?
All right. Just before that, the whole maximal tolerated ACE, I think, is a very important thing. ACE inhibitors across a number of different spectrums, hypertension, CKD, all those aspects. It comes, it rears its head now every single time. And I think it's always an important thing to kind of maximum tolerated doses. And as you see with blood pressure, same with HbA1c, you want to get it down as low as and safely as possible. And that's where kind of a lot of, you could argue whether it's 53 millimoles per mole or 48 we want to go for in Fatima's case. Same with the blood pressure, is your 130 over 80, or would you want to go even lower in some, you could argue those cases for all that. And then I think that's what's, that individualized care and that individualized approach kind of accounts for that and looking into that.
We do see that U-shaped mortality curve, don't we? If we go too tight with the blood pressure. So I suppose we have to be a wee bit cautious. I know we had data from Sprint a few years ago suggesting the lower the better, but Sprint, like any trial, Sprint wasn't the perfect trial. So I suppose you hit the nail on the head. It's about the individualization of that blood pressure target, isn't it?
And you have constant arguments about blood pressure and that thing. So it's one for another day. But yeah, as I said, essentially in this lady, as we as we suspect, we're thinking of heart failure here, and so the whole point is about diagnosing it. It's really black and white in my neck of the woods. In kind of in secondary care, they come in with the symptoms. I'd straight away say, okay, I want to do a blood test for NT-proBNP, and I want to do a echocardiogram, a heart scan, just to see what's going on with the heart function. But then again, I mean, everything's different from a primary care setting. I imagine there's different ways of doing this at pathways, not as just bang doing it as we tend to do in secondary care for whatever reasons. Amrit, have you kind of, where you are, what do you do in this situation?
Yeah, absolutely, you're right. It does vary from CCG to CCG, locality to locality. In our area, it's very much based on the symptom assessment. If you're suspecting heart failure, based on the history and examination. If the patient has had a previous MI, they actually fit into the rapid referral kind of pathway. So within 2 weeks being seen by the heart failure team in secondary care. They haven't had a previous heart attack, then it's a case of risk stratifying based on the NT-proBNP. And anything between 400 to 2,000 would be a referral to a routine referral to the heart failure team. Anything less than 400, we're thinking of other causes of the symptoms, essentially ruling out in that situation heart failure. So that's what we do in our locality, but I'm sure it varies from place to place. Patrick, what's it like over with you guys?
So ours is very similar to yours, Amrit, in a sense that we don't have, if they've not had a previous MI, they just, everybody goes into the same pot. And again, we're risk stratifying. Once you've got the clinical suspicion of heart failure, you would be doing the NT-proBNP. And again, same cutoffs, which are based on NICE, of course. So that you can directly refer to the heart failure clinic, because obviously not all patients with heart failure will actually have a elevated NT-proBNP. So if you've still got a strong clinical suspicion, you can refer directly, but the usual pathway is to be checking the natriuretic peptides and taking it from there. What about you, Kevin?
Yeah, so we've had quite a good pathway in place over the last couple of years if I suspect heart failure in any of my patients. So there's a fast track referral system. I check bloods for NT-proBNP within 2 days, ideally, of the electronic referral. And then actually the consultant-led clinic takes over from there. They'll triage that NT-proBNP result. If it's negative, as you said, it'll be bounced back to me to look for other causes of breathlessness, peripheral edema, etc. But if it is positive, they'll go on and organize an echo. They'll establish a diagnosis of heart failure as appropriate, and they'll also initiate medication and start titrating it. And once that patient stabilized, they'll be discharged back to my care. So I've got to say, we've got a very robust pathway. It's taken a couple of years for that to come into place. But it works, it works very well. And despite the challenges of the pandemic, that has continued to run throughout the pandemic.
I was just going to take a couple of steps back, actually. And just as a point, I think one of you mentioned was that if we suspect it's heart failure, this is what we do. But clearly we can see from the fact that there's such a big gap in the actual prevalence versus the coded prevalence of heart failure in the UK. There are certainly cases where patients are presenting with breathlessness where these steps aren't being taken for a number of reasons, because it's not always so clear cut. And something that jumped out at me is that I mentioned earlier on, out of those 8 in 10 new diagnoses of heart failure take place in the acute setting. Well, out of those patients, about 40% of those patients have actually presented to their GP within the last 5 years with symptoms suggestive of heart failure. So there's still something there. It's not very clear cut, it seems, and there are lots of factors it seems to be at play that aren't allowing us to identify these patients so easily.
But these symptoms of heart failure by themselves have very poor positive predictive value, don't they? Of course, if they cluster together, that makes things a little bit easier. I have a very elderly population, as I've mentioned to you, in the past. So over the age of 65, 1 in 6 people presenting with shortness of breath will have an underlying diagnosis of heart failure. So that still leaves 5 out of 6 people with another cause of their breathlessness, doesn't it? So, I appreciate where you're coming from, Amrit, but as you said, it's not always so straightforward, is it? When someone presents with shortness of breath in primary.
And from a secondary care, I have it all right there for whatever reason. So I get the blood test, I get the ECG, and it's getting showed LVH, which we know there's already evidence that the hypertension is causing a bit of heart pressure. I'd get a chest X-ray, I'd do some blood tests, I'd get them all back within a day or two, and I'd see all the evidence of heart failure already there. So it misses a large portion of the people who don't present so obviously, because I wouldn't be doing those tests if I didn't have such an obvious history as it is here.
Yeah. And I think in defense of primary care, as you say, Amar, there's a huge issue with multimorbidity. So often these these individuals have got quite a complex history, and it's a challenge in a 10-minute appointment to cover the umpteenth clinical problems, which might include breathlessness alongside it, and appropriately prioritizing it. So I think it's another one of the challenges that we face in primary care.
I was just looking at my heart failure register in preparation for this session, actually, and it was amazing the number of patients on the heart failure register who also had a respiratory condition diagnosed as well. So there you go. There's your, straight away, one of the commonest causes of breathlessness, asthma, COPD.
Well, that was a top tip I got from one of our local consultants. You know, my patients living with COPD, if I'm thinking of escalating from dual inhaler therapy to triple therapy, what is a common misdiagnosis? Heart failure, isn't it? So look a wee bit harder, look a lot harder. Are there any symptoms or signs of heart failure in that person living with COPD? So I thought that was a great practice pearl from one of my local secondary care colleagues.
And they are linked as well, isn't there, with the right kind of heart failure and pressure, so you can't escape it anyway, in a way.
Yeah. So I suppose I should tell you what happened to Fatima, didn't I? So I did an urgent referral down my suspected heart failure pathway, and I at the same time checked NT-proBNP, and that actually returned at over 2,000. So what do we all think of that? What do we do next?
Well, I think we're obviously going to be discussing this in a little bit more detail in the coming weeks. But I think, yeah, we've already touched on a lot of our kind of actions through the discussion we had about our local pathways. But it'll be interesting to see exactly what we do. And I think we obviously have to remember the patient in this situation as well. And how, you know, although we might be following a pathway, how we bring the patient along with us and ensure that they're aware of exactly what this all means. So I'll be interested to hear what we discuss in our coming sessions.
Can I have a shout out for one treatment at this point? No, I'd give her some water tablets, some frusemide maybe, to improve her symptoms, even whilst we're trying to work out what are the treatments which are going to hopefully keep her looking after the little Fatimas for a lot longer.
Absolutely. I mean, that can be diagnostic in itself as well, can't it? That symptomatic improvement with diuretic. My last parting point was just the terminology. Heart failure is not great, is it? You know, when you try to, you know, we've got this potential diagnosis, and you discuss that with Fatima, you know, just the connotations about heart failure. It's something that I think that perhaps down the line probably needs to be some sort of new terminology. I think. From a patient perspective, I just think it's not great terminology.
I would wholeheartedly agree with you. I always apologetically introduce the topic, saying this is a dreadful term I'm going to use, but it's sometimes described as heart failure, and then I try to put the positive spin on it and say, but there's a lot of new treatments, there's a lot we can do to improve matters. It's not as bad as it sounds, but yeah.
I think that's the important thing. So the things that we can do, and that's the important thing, and we will discuss that, won't we, in the future.
I think
that's... You want to round up then, Amrit? Or...
Yeah, no, I think that's a good point, and a positive note there as well from Amrit at the end as well, that there are options in terms of management, but a good point to pause for us to reflect perhaps, and to wait in anticipation of the GoggleDocs discussion of where to go next. We are going to be calling upon the experts and specialists who are involved in heart failure and cardiology care, not only in the community but beyond. So look out for those in our coming episodes in the following few weeks. But until then, thank you very much for joining us today. I thank the rest of the group for their discussions as well. If you like what you saw, please do subscribe to our channel and add any comments that you wish to make. And we look forward to seeing you in a week's time. Take care. Goodbye.
Bye-bye, everyone. Bye-bye.